All right, so this morning I'd like us to have a conversation in our studio here with Dr. George Kizuka, who is the Prevention Mother-to-Child Treatment Program Manager at NASCOP, and also Dr. Loice Ombajo, who's the Chair HIV Clinicians Conference. So this morning it is about HIV/AIDS infections, how to prevent the mother-to-child, when you talk about prevention of mother-to-child treatment, and also new infections and infections of HIV/AIDS when it comes to adolescents of the age of 15 to 19. That is a discussion that we want to have here in our studio this morning. Thank you so much for joining us here on KTN News Center. And Dr. Tari, I'll start with you. When it comes to HIV in adolescents and young people, where are the gaps in Kenya?
Okay, thank you very much. I think to go straight to your question, HIV in adolescents and young people is a field that the HIV program has made a lot of progress, but as you have highlighted, there are still several gaps that exist. When you look at HIV in this group, we are talking about first, the ones who acquired HIV from their parents through the mother-to-child transmission of HIV. And due to the effectiveness of the drugs, the antiretroviral drugs, they have grown up to be adolescents and young people. And it's a special group of a category. As they mature, then how are we able to manage their transition from childhood to adolescence and to adulthood? The second one, which I know you are highlighting, is the issue about the ones who become infected sexually between the age of 15 to 19, between the age of 20 to 24. And this is a group that has been realized to be where most infections are again occurring, especially amongst the young women. And the gap there that we are trying to address is the issue about knowledge first, and that knowledge transitioning into behavior change, and empowering the young people to be able to take actions to prevent themselves from HIV.
Okay, and there's the risk and vulnerability of girls in HIV, because recently there was a study that was released that showed that young people are not afraid of being infected, rather they're afraid of just being pregnant.
Yes, and I think that's a consequence of the effectiveness of treatment. You know, the images that have previously been there as regards to HIV infection. Due to scale up of efficacious treatment regimens, those images have disappeared. And you know, pregnancy is something that is going to be seen and result to a child. So I think the main thing, as we are saying, is to try and continue intensifying our communication to that age group, to say that it's a two-pronged approach to prevent unintended or unwanted pregnancy in this age group, to prevent other sexually and HIV. Okay. So the message for HIV needs not get lost. Yeah.
Okay, let's bring in the conversation of PrEP. 2 years, where are we right now? And especially couples who are disconduct.
Okay, thank you for that question. So when we talk about PrEP, we refer to prevent them from acquiring HIV from a positive person. And this program was almost 2 years ago in the country, and there's a pill, a once-a-day pill that's taken to prevent this infection from going on. There's certain things that need to be done before someone is initiated on PrEP. So one, we want to make sure that your HIV test is negative, and even once on PrEP, we continue to test to make sure that someone stays negative. And the reason we do this is because we don't want to give someone who's HIV positive what would be suboptimal treatment. So the rollout has been going on, but the uptake has not been very good. I think some of the challenges we have as clinicians when people come in and ask about PrEP is once you tell them about the need for repeat testing, there's always a bit of hesitation. They want to come and say, I'm negative, I want PrEP, and that's it. But there are reasons why we have to keep testing. So that hesitation has sort of hampered the uptake of PrEP. The other thing is that if someone is on PrEP, they have to take it every day for it to be effective. It's difficult to get someone who is well to take medicine every single day. So again, that becomes a challenge. People start and drop off after a short while. And there are people who only want to take it when they perceive that they are at risk. So they ask about something that they can take just before the weekend, for example, and not subsequently. And when we have the conversation around the need to take it until such a time that we evaluate the risk as having gone down, then there's always a bit of hesitation. But PrEP works if taken well, and we'd really encourage everyone who's at risk to talk to their healthcare provider, who will walk them through the journey of taking PrEP up to a time when that risk is lower.
But Dr. Ombajo, one question is, what if a couple they want to have a child, and of course PrEP is when one couple is positive, the other one is negative. So what happens?
So the way we do it is this: when we have a couple, what we call a discordant couple, where one partner has HIV and the other partner does not have HIV, before or soon after initiation of treatment in the HIV positive partner. So that's the most important part, that the HIV positive partner is on treatment. At the time we start this treatment, the HIV negative partner is initiated on PrEP as well. And ideally we want them to use PrEP for a period of about 6 months. And this 6 months is to allow the positive partner to have a suppressed viral load. A viral load that is so low, we'd call it undetectable viral load. When the viral load is that low, the risk of transmitting to the negative partner is minimal. And at that point, we encourage them to continue to use other preventive measures, such as condoms. If in the event that they want to conceive, it means that during that time they will not be using condoms, then the negative partner can be put on PrEP again for that period of attempting to conceive. And after that, they can go back to just using condoms, as long as the positive partner continues on treatment and their viral load is suppressed.
So is that likelihood that the child will be born negative and that the mother or the father, either of the couple, either of the partner will end up, after that long process, will come out negative?
Yes. So all the studies that have been conducted in couples that were discordant show that as long as the positive partner is taking medicine and is suppressed, then the negative partner will stay negative. So the most important part is that the positive partner is suppressed.
Okay.
A child who's born to a mother whose viral load is suppressed, the risk of transmission to that child is also very low. And there are other processes that we take this mother and the new baby through to minimize any risk of transmission. And where that whole process is adhered to, the risk of transmission is minimal.
It's
extremely
minimal.
low.
It's minimal. So let's talk about PrEP when it comes to sexual workers. Are they encouraged to take PrEP, and do they adhere to that?
So maybe we'll talk briefly about what sort of risks are considered to be high risk enough to have PrEP, to give someone PrEP. So if someone is a sex worker, for example, then yes, PrEP is useful, and they should use the PrEP consistently for the period of time in which they engage in the sex work.
Okay.
The other risks are where someone has a partner whose status they do not know, or someone has multiple partners, or someone has had a sexually transmitted infection, which means they've engaged in unprotected sex. So those are situations where we'd encourage that that person is put on PrEP for the duration that they are at risk.
Okay, so let's talk about sexually transmitted infections in pregnancy and the plans for improving screening for STIs. Yeah.
Sexually transmitted infections in pregnancy are also a priority as they impact the outcome of the pregnancy. If I'll give an example, syphilis is the second leading cause of stillbirth after malaria. And congenital syphilis, or syphilis is transmissible from the mother to the unborn child, who will be born, as I've said, either with stillbirth or congenital syphilis, which again leads to early death of the child. So in Kenya, one of the key priorities, as I said, is syphilis, and we are rolling out HIV and syphilis dual testing, where we have one test kit that tests for both HIV and syphilis. And when the mother is found to be positive for either, then they are put on treatment. And syphilis is an easily treatable infection, and once treated, then the risk of it being transmitted to the child reduces. So that's one of the key priorities. Even as we talk about elimination of mother-to-child transmission of HIV, we're actually talking about dual elimination, or including of syphilis. But if a mother is found to be at high risk for other sexually transmitted infections, for example, if they test positive for syphilis, or if they have signs and symptoms of any other sexually transmitted infections, they are treated and managed in a syndromic approach. And most sexually transmitted infections are treatable. Yes.
Okay. So how successful has this test kit been? Do Kenyans know about it?
Yes, the test kit, the HIV and syphilis dual test kit started being rolled out earlier this year, and we are rolling it out in the entire country, mainly targeting pregnant mothers. As you know, when a mother goes for antenatal clinic visits, they are supposed to be tested for HIV, syphilis, amongst other tests. And through the Linda Mama, they do get this test free. So any mother who's coming to a facility, they are getting all the antenatal clinic tests profile free. And to improve on efficiency, the dual test kits test both, as I said, syphilis and HIV concurrently. And at the point at which the mother is being given the service. So they're able to get the results immediately and they're put on treatment. So it's been successful. The uptake has been good, but we still need to sensitize both the healthcare workers more and also the mothers more, so that even as they go to the facility, they know what to expect in terms of the tests.
Yeah, and when you talk about the test, you know, probably a viewer might be wondering, this test, when a pregnant woman goes for this antenatal clinics, is it optional? Do you have an option of telling your doctor, no, I don't want, or it's mandatory that you have to go?
Well, you know, every patient has their rights, so they can choose to have the test or not. But normally we don't have many who opt out.
Okay.
Because I think this is for the sake of the mother and the unborn child.
Okay.
And I don't think there is any mother who would want to put their child at risk. So the acceptance and the uptake of this test is generally very high. The counseling that is provided to the mothers before these tests are conducted also helps them, you know that the test is not just for the test, is in case anything is found. Then treatment is available, and it will be able to safeguard both the mother and the child. Okay.
So right now, as a country, we are working towards eliminating the mother-to-child. It's the program of mother-to-child treatment care, and I'd like us to have a look at the PMTCT on a Super Bowl this morning when it comes to the prevention of mother-to-child treatment here in Kenya, because we are working as a nation to ensure that that transmission of HIV/AIDS is no longer there. So it is mother-to-child transmission. So on a Super Bowl this morning, the approach to the PMTCT, it is that we are working towards preventing HIV among women of reproductive age. We are also working towards preventing unintended pregnancy among women living with HIV, and of course, to prevent that, and also HIV transmission through the antiretroviral treatment during pregnancy and breastfeeding, and also treatment care and support for mothers living with HIV, their children, partners, and families. So that those are like, I may say, 3 areas that that the country is working towards in ensuring that we have the PMTCT successful. But Dr. one question is, there's one that says that prevent unintended pregnancy among women living with HIV, prevent HIV transmission through antiretroviral treatment during pregnancy and breastfeeding. So a woman who's breastfeeding can also be put on the medication, on the antiretroviral. So does it affect the breast milk?
So the antiretrovirals that are used in women who are pregnant or in women who are breastfeeding are safe for the unborn child and for the child who's breastfeeding. On and off, there may be occasional concerns because it's very difficult to conduct studies in pregnant women. So every time a new drug comes out, it takes a few years before we know whether it is safe in pregnancy or in breastfeeding. The drugs that are available in the country are safe in children. Recently, people may have read in the papers, there was a bit of a concern around one of the drugs because in one of the countries they thought it was associated with some issues in the unborn child. So for that reason, as a country, what we have said is if a woman has pregnancy intention, that means they're not on effective contraception, then we want to avoid using that drug in pregnancy. Other than that, we have other regimens that are safe, other drugs that are safe in pregnancy and in breastfeeding. And any woman who is HIV positive should be on treatment. Women who are pregnant should immediately have their HIV test, and if positive, treatment should be initiated. And this treatment should go on beyond the pregnancy and beyond the breastfeeding period to ensure that the virus is suppressed so that it's not transmitted to the child.
So how successful have we been as a country, as Kenya, when it comes to the mother-to-child transmission?
Yes, when it comes to the prevention of transmission from mother to child for HIV and syphilis, we've been successful as a country. Intensified programs started around 6 years ago in the year 2012, where the transmission rate was at 16%, meaning 16 out of every 100 children born of mothers who are HIV infected were acquiring HIV from their mothers. And we made a lot of progress through introduction of efficacious treatments to the mother, and also prophylaxis or preventive medication to the children born of mothers who are HIV positive. So you've seen that transmission rate drop from 16% to as low as 8%.
So from 16% to as low as 8%.
To as low as 8%. And what we are targeting to by next year and sustaining it through the year 2021 is to see that this is reduced to less than 5%, and we keep it that way. One of the challenges we've had within our health sector, as you know, is that it's a fragile health sector because of the, sometimes we get industrial actions by our service providers. Remember last year there was a doctor strike, there was a nurse strike, which set us back a bit. But so far, if you look like this year, there has been no such actions taken. We have all the drugs and commodities available. So we are optimistic that we would be able to get to that target of less than 5%.
Okay.
But over and above just mentioning the figure 5%, we have to see how do we get there.
Yeah.
And for us to get there, we need to have all mothers, both those who are known to be HIV infected, the ones who are of unknown status, or the ones who are known to be HIV negative, have to attend antenatal clinic care visits.
Okay.
And as I said earlier, these services are free through the Linda Mama program. And if you get over 95% of our mothers who are pregnant, at least attending one antenatal clinic care visits, and having over 95% of them tested for HIV and syphilis, and having over 95% of the ones who are found to be infected put on treatment, that will automatically lead us to achieving that target. And we need to sustain that performance. So I think over and above just focusing on the target, we need to ensure that we keep our health system in place to be able to sustain this. And also ensuring that almost over 95% again of all the mothers deliver within a health facility.
Okay, over 95%, Dr. Ombajo, deliver within a health facility, and just to ensure that we get the targets. But what happens to women who are breastfeeding and then far-flanked areas, and they don't even know about these antiretroviral drugs?
Wow, that's a difficult question. I think most health facilities in this country can provide antiretroviral therapy. The biggest challenge we have, as Dr. Githuka said, is where a woman presents late in the pregnancy, which means if the woman was positive, you don't have enough time to suppress that viral load. Or some women present in labor already. Again, the risk of transmission is a little higher. So I think it's really to get everyone to know that these facilities are available. Of course, there are places where people may have to walk many kilometers to get to a health facility. And I hope the county governments look into those issues. But the main aim is to get people to present early enough, early in the pregnancy, so that there's sufficient time for them to take the antiretroviral therapy and suppress the virus before delivery. Delivering within a healthcare facility is also important, because if the mother is positive, there are medicines that we give to the child as well to, again, just make sure transmission doesn't occur. And if the delivery is at home, then we lose that opportunity to also give the child the medication. So having the child tested at birth is also important, or soon after birth, because in the event that there's any transmission, then we want to start treating that child very early, because children who are born with HIV are at higher risk of dying because of the HIV. So starting that child on treatment early, having the child tested soon after birth, and following up with a clinic visit so that the testing is repeated is also important.
And are there situations, Dr. Ombajo, where a mother has been told you need to stop breastfeeding and give your child an alternative milk?
So for I guess a number of years, we thought that if a mother is positive, then they should not breastfeed the child. I think more recently, we have sufficient data from large studies that show that if a mother's viral load is suppressed, then the risk of transmitting to a child through breastfeeding is low. So a mother who's suppressed can breastfeed the child is given certain treatments. We also recognize that in situations such as ours, getting safe alternatives to breastfeeding is not always easy. And children who are not breastfed actually have more adverse outcomes. The risk of dying in a child who's not breastfed in low resource settings is higher. So we are actually encouraging mothers to breastfeed their children. The mother is on antiretroviral therapy, the child is on prophylaxis as well. Yes.
Okay. Let's talk about HIV in the aging and the aged. How's it been?
So I guess the issue of aging and the aged is sort of two-pronged. One is that as we have good treatments, as you referred to earlier, even with the youth and adolescents, as we have good treatments, people are living longer. So at this point, we have patients who've been on antiretroviral therapies for 30 years or even more, and they're doing very well. But in those 30 years, they've also grown older. But you also have those people who acquire the HIV when they're older. So those are sort of two sets of people. When they take their treatments, they do well, and older people tend to adhere to their treatments a little better. The concerns we have is that as we grow old, everyone who grows old, we tend to get certain what we call comorbidities, other diseases that come on board. For example, hypertension, certain cancers, for example, diabetes, lung diseases that may be more common in those who are older. So as people grow older, we have to think about how the many medicines they have to take for these other comorbidities interact with their antiretroviral therapy. They may have to take more pills in a day, so the pill burden becomes a concern. And then we have to screen them more. So if you see a 20-year-old, you're probably not concerned about screening them for high blood pressure and diabetes. But if you have someone who's 60 years old, then we have to be a little more vigilant in screening for these other diseases that may occur in those who are older.
Okay. And Dr. Kizuka, that it might be concern also, especially HIV and AIDS when it comes to the age of the adolescents, 15 to 19. Is there a connection between gender-based violence and HIV?
Yes, there is a connection between gender-based violence and HIV. As I said earlier, quite a big proportion of the people who have HIV between the age of 15 and 19 have also acquired it sexually. And this gender-based violence is one of the main ways, because of course there is a disadvantage if you have an older man, to use the word preying on a younger adolescent, then that she's not empowered to be able to for example, negotiate for use of condoms, or to be able to understand the situation very well. So part of the interventions that are in place to address HIV transmission or prevention amongst that age group is addressing the issue about gender-based violence. And if that is addressed, then quite a huge proportion of HIV transmission amongst that age group is going to reduce.
Okay, thank you so much, Dr. George Kizuka, seated next to me, who is the program mother to child transmission program manager at NASCOP, and also seated next to him is Dr. Loice Ombajo, chair HIV CLINICIANS Conference. He's talking to us about HIV and AIDS prevention in the country when it also comes to the mother to child transmission, how far we are as a nation with that far. And of course, Dr. Kizuka, you've told us we are actually there. We are remaining with about 5%. Yeah,
we are remaining with about 5%, but you know the last 5% is the most difficult one. Because it's the people who are hard to reach that now we are trying to target.
Okay, thank you so much, Daktari. And